My name is Tamer Amara. I'm a neurologist from Ain Shams University, and I work in Ain Shams Virtual Hospital. I would like a few remarks before starting. We will be, all of you would be muted for the discussion, but you can talk or you can text any question either in the chat box or in the Q&A section in your Teams. We'll be happy to get back to the questions between the talks of the panelists. We also will be we'll have two presentations from Professor Nasreen from the Health Economics unit in University of Dhaka, Bangladesh, and from Di Liang, Associate Professor of Public Health from Fudan University. And we'll be having verbal interventions from Professor Wael Rais and Professor Sheli Prasad from Universities of Nebraska and Minnesota, respectively. We are waiting for 1 or 2 minutes because a few people are joining now, and then we'll start immediately. Thank you. So I think we'll be starting now with Professor Nasreen Sultana.
Yes.
Professor Nasreen, please share your slides and start your presentation.
Okay, thank you.
Thank you.
No.
Professor Nasreen, we saw your slides for a second, and then
I am trying to share. I am trying to share. Can you show my slides? Can you see my slides?
We can see your screen that has the Teams open and the videos, but not the slides.
Okay.
If Dr. Nasreen has a problem with the displaying her presentation, can you use yours, Dr. Tamer, if you have the presentation?
Yeah. If you allow me, I can present from my slides. Okay. Maybe there is a problem. Okay. The issue was excellent. Thank you very much for giving me the opportunity to say something about the universal health coverage towards global health security in Bangladesh. This is Professor Nasreen Sultana. I am working at the Institute of Health Economics, University of Dhaka, and I am working in that field for the last 25 years. First of all, I would like to discuss what issues to be presented here. Yeah.
I'm sorry, but we cannot see your slides yet.
I am trying to share this, but I cannot do that. The screen. What are you seeing in my screen?
Yes, now we can see it. Yeah, perfect.
Okay. Accelerating universal health coverage towards global health security in Bangladesh. Issues to be discussed. The overview of health sector of Bangladesh, USA and its present status, situation analysis of global health security, USA towards global health security in Bangladesh. In fact, Bangladesh is a country that hosts 170 million people with an area of 148,460 kilometers. Its economy has been growing at an average rate of 7% per annum, and it is on the track to become a middle-income country by 2022 from least income countries. And our health sector has two divisions, health service division and medical education and family welfare division. It involves the multiple tiers of service entities that start from the community level to the national level. And if we see the service delivery structure of Ministry of Health and Family Welfare from top to bottom, we have found that there are two divisions. One is health service division, another one is medical education and family welfare division. Under health service division, there exist DGHS, that is Directorate General of Health Services. And under the MEFWD, there is a Directorate General of Family Planning Services. These are the two components that are given by two divisions. And like there are division director office, district level civil surgeon office, at Upazila level, USFPO and UFPO office, etc., etc. And our healthcare facilities are segregated into three different levels or three different tiers. Tertiary level, basically medical universities, medical college hospitals, and specialty hospitals deals with the tertiary level hospitals. They gave care for tertiary level. And for secondary level, we have district hospitals, general hospitals, maternal and child welfare centers. At the primary level, we have Upazila health complexes, Union Health and Family Welfare Center, and community clinics. These are the basic different levels of healthcare facilities that are prevailing in Bangladesh. And if we look towards the universal health coverage, then we all know that there are three dimensions of USC, that is population coverage, service coverage, and financial protection. And basically, it covers the full continuum of essential health services from health promotion to prevention, treatment, rehabilitation, palliative care, and across the life. And if we connect the relationship between ESC and HDC, we have found that the HDC target 3.8 directly deals with the USC. And there are two targets of this goal, 3.81 and 3.82. 3.81 says that health service coverage that is achieving at least 80% coverage of essential services for the entire population. And 3.8.2 says that financial risk protection, ensuring 100% protection from the catastrophic health expenditure. So if we look towards the USC profile in Bangladesh, we see that since USC is a key target of SDG 2030, integral to mitigating global inequities and poverty with commitment from every UN member state, including Bangladesh. In light of this, in 2012, the government of Bangladesh developed a healthcare financing strategy to enhance financial protection and expand health coverage with the aim of achieving USC by 2032. Subsequently, Bangladesh committed to attaining USC by 2030 under the Sustainable Development Goals. The government of Bangladesh reaffirmed its commitment to achieving USC by 2030 and promised to speed up efforts through measures like revising the current essential service package, enhancing affordability, increasing resources, and emphasizing public provision of healthcare for all to reach the objective. If we look towards the USC Service Coverage Index, as we know that USC Service Coverage Index combines 14 tracer indicators of service coverage into a single summary measure under 4 main areas. And if we look to the results of that indicator, we find that our achievements are basically high for immunization. 98% populations are immunized in our country, and the worstmost conditions are for health workers density, maternal health condition, and child health. But more or less better condition exists for family planning coverage, immunization, health security, normal BP, and tuberculosis. And if we look for trends in USC Service Coverage Index of Bangladesh, we find that the present condition we are at, our present index is 52, and we have projected that at 2030, if we go through in the same pace, then we can achieve 60 to 61 2030. But our target is 80. We are lagging behind our main target. And if we compare the USC Service Coverage Index with the world average in South Asia, we find that in the last 20 years, from 2000 to 2021, there is a huge improvement for Bangladesh from the index 23 to 52. But this is a very small size in compared to world average or South Asia. If we look for the essential service package population coverage in public sector, and we find that our present situation, this service 33, and if we go in for the same space and we can achieve only the 50% population would be under our population coverage. This is, we are lagging behind. If we look for the second USC goal 3.8.2, that is catastrophic health expenditure, then here we compared our catastrophic health expenditure with our CRO countries, then we find that the catastrophic health expenditure for Bangladesh is almost 25%, and it is the highest among the CRO countries. This is the situation for USC, current situation of USC in Bangladesh. If we look for global health security, we see that like the US index, global health security index is done based on the 6 categories of 37 indicators and 96 sub-indicators. And if we look for the results for GHS index result, and if we compare with the other countries, then we find that for Bangladesh case is 35.5, where the developed countries case, this is all about almost 75%. And if we compare our global health security index for year 2019 to 2021, we find that these 7 categories indicator: prevention, detection, response, health, norms, and risk. We find that our good condition is for detection. That was found in the case of in time of COVID-19. Our detection rate or our case handling was very good. And our risk, we are very well in case of risk protection and detection compared to others, but our worst condition is for prevention, then health condition, and responses. if we score on different pillars of the index, and if we compare the Bangladesh case with the others, different pillars of the index with the global average, then we find that only in case of overall score, our score is 35 points, but in all cases, except detection, we are lagging behind. In case of prevention, response, health, norms, and risk, in all cases, we are lagging behind than the global average. Now the question is why we are lagging behind, why we cannot achieve the good score for Global Health Security Index or US Index. The basic thing is that while the primary healthcare services help to achieve the notable success, secondary healthcare in Bangladesh remains underfunded and poorly managed. That is the main condition. The main fact is that in Bangladesh, the national budget for health sector is underfunded. It is a very small amount compared to our country's need. Despite being faster growing economy in the region, Bangladesh invests lower than the regional average in healthcare. On the other hand, there is a lack of readiness, human resources, there is a shortage of diagnostic, ambulance services, communication, digitalization. Moreover, there is a huge lack of coordination and mismanagement between and among the different ministries and different levels of hospitals. So if we look to the indicators of USC and the indicators of global health security, we have found that in case of USC, there are 14 indicators. They are categorized into 4 types. And in case of global health security, there are 6 categories of indicators. And if we compare the indicators among USC and global health security, we find that the case 2 and 4 that deals with infectious diseases and service capacity and access both are same. The theme for the USC and the GHS are same, but only case of reproductive, maternal, and newborn child health, there is no global health security issue, and for non-communicable disease, there is no GHS issue. On the other hand, the risk environment is only for GHS. So we can say that among the four categories, 2 categories are overlapped and twos are different. So if we want to achieve the global health security index or the targets of global health security or the targets of US, we cannot achieve single. We need to work jointly. Now I would like to add something, that is, if we want to see you the global comparison of healthcare financing in Bangladesh, you can see that our per capita health expenditure is $54, which is a very small amount, very least amount compared to the other neighboring or South Asian countries. On the other hand, another challenge is that our out-of-pocket expenditure is 68.5, almost 69% expenditure came from our pocket. So this gives or falls our poor people into impoverishment or catastrophic health expenditure, and our government spending is only 23%. If we look for the health financing in Bangladesh, we see that the trend is our per capita health expenditure is increasing. It starts from $16 to 2007, and now it becomes $54. Whereas the public expenditure was $27, now becomes $23. That is, our per capita total health expenditure is increasing. At the same time, our public expenditure on health is falling but decreasing. And since public expenditure is decreasing, our out-of-pocket is increasing. And if we segregate the out-of-pocket expenditure, we find that among the 69% out-of-pocket expenditure, 64% goes for medicine. The huge cost for medicine cost, that is 64%. The second thing is that our outpatient care and then diagnostic centers cost. Now, if we look for the allocation utilization of Ministry of Health and Family Welfare budget, then we'll see that the trend is in absolute term, the total amount is increasing. But if we see that if we do this as a percentage of national budget, that is, the rate is around 5%, almost around 5%. And this budget is below the 1% of national budget, whereas the WHO recommended that health sector budget should be 15% of a national budget, but this is only around 5% of Bangladesh, though the budget in absolute amount is increasing. Government is trying to achieve, to accelerate the USC for becoming a smart Bangladesh, for becoming global health security. So what should be the possible strategies for achieving USC in Bangladesh? Increased public share of health budget as well as pooling of funds from different sources is essential. Another thing is that primary healthcare strengthening as a core element of the USC. So we should strengthen the primary healthcare center, and we should increase public expenditure on drugs to ensure availability of essential drugs at the PSC facilities so that the medicine cost can be reduced. On the other hand, appropriate measures for ensuring social health protection, this can be another way. Improve efficiency in research allocation and use, and ensure equity research allocation distribution is also a required thing. So what we need to do for achieving global health security in Bangladesh? Same thing, we should allocate more funds for health security. Countries should allocate health security funds in national budget and conduct assessment using the latest GHS index to develop a national plan. Additional support from the international organization is also needed to identify current countries' most needed part. Involvement of private sector. The private sector should use the GHS index to look for opportunities to partner with the governments and new financing mechanism. Philanthropists and funders should develop new financing mechanism and use the GHS index to prioritize resources. So we can say that in case of both USC and Global Health Security Index, we see that in the last 20 years, our trend is increasing, but we may fall short of SME's target by 2030 and the global average of GHS index. Among the 14 tracer indicators of USC, Bangladesh has reached the 80% target for only a few tracers, say immunization and tuberculosis, but the other indicators have not shown the satisfactory progress. On the other hand, in terms of 6 indicators of GHS index, Bangladesh performs worse for prevention and health system. Accelerated development is needed, including USP expansion and improving service coverage, capacity, and accessibility. More emphasis should be given on preventive and promotive care. So what issues should be addressed, or what issues should be addressed to improve the USC and GHS index in Bangladesh? We need to give importance on funding. That is our underfunding health system. Our funding should be increased, and there is a huge shortage of manpower in Bangladesh. If we look for the proportion of population doctor ratio, if we look for the doctor nurse ratio, if we look for the doctor and technician ratio, in all cases, almost all cases, we are lagging behind and there is a huge shortage. On the other hand, there is infrastructural gap, there is a logistics, we have some logistic challenges, and there is access to health financing. Financing is a big issue for Bangladesh, and high out-of-pocket expenditure is a big crisis for Bangladesh. So the issues related to the human resources for health should be addressed to achieve, if we can achieve, would like to achieve the both USC and global health security. Finally, I can say that to achieve the global health security, there is no option, there is no alternative without USC. Since these are the joint effort, with the joint effort, we can achieve both this. Thank you all. Thanks for your patience hearing.
Thanks very much, Professor Nasreen. Apologies for joining late. This was definitely an excellent presentation, very comprehensive. And I think that you summarized it very eloquently in your slide number 30. Our second presenter this afternoon, morning, or evening, depending on where you are on this planet, is from China. We are going to listen to Dr. Di Liang, who is an assistant professor of health services research at the Fudan University. Her presentation is going to be on promoting synergies between universal health coverage and global health security, but this time in the Western Pacific, as opposed to the Southeast Asian nation of Bangladesh. So Dr. Liang, the floor is yours.
Thank you, Dr. Mandio. So today I'm going to talk about the current status of the synergies between universal health coverage and global health security in the Western Pacific region. Okay, so next slide. So as we know, the UHC and the GHS are the two key global health agendas, and they should be pursued synergistically. However, we have seen that the fragmentation between these two have occurred worldwide, and also the past COVID-19 pandemic has further exacerbated or exposed this issue. Okay, next slide. And in this study, we focused on the Western Pacific region. This is a very interesting region because the countries or territories within this region, they are very diverse, both in terms of the size of population as well as the level of social and economic development. So in this region, we have China with more than 1.4 billion population, and we also have a handful of Pacific island countries or territories with only a few thousands of the population. Okay, next slide. And there is also a huge gap in the GDP per capita in this region. We have Singapore, Australia, New Zealand, Japan, and a few others high-income countries. And however, most of the countries or territories in these regions are classified as upper middle or lower middle income countries, according to the World Bank standard. Okay, next slide. And so the first part of this presentation is about the current status of the synergies between USC and GHS in the Western Pacific region. And basically, we look at the how the measures of the UFC and the measures of GHS correlate with each other. And for the measures of the UFC, we just as the Professor Nasrin, we choose the Universal Health Coverage Service Coverage Index, and it combines indexes from 4 dimensions, and I will not. If you have more questions, I can explain on this later. Yeah, next slide. So here is the current status of the Universal Health Coverage Service Coverage Index in this region. As we can see in this figure, we have a few countries, mostly high-income countries, and also some other upper middle-income countries, such as Singapore, Japan, and also China has a UHC score higher than 80 in the 2020. However, on the left side of this figure, we can see that many of the Pacific Island countries or territories, they have a much lower scores in the UHC SCI scores. And our measure for the global health security is the GHSI index. So this is also the same as what Professor Nasrin has just presented, and it also combines sub-indexes from 6 dimensions: prevention, detection, response, health system, compliance, and risk. Okay. As we can see here, this table on the right-hand side shows how this country performed in the GHS according to the Global Health Security Index. And we can see here that generally speaking, the overall achievement in this region are not as good as the UHC. And we can see that many of the countries stay the same between the 2019 and also the 2021. And also many of the Pacific Island countries and the territories, they scored quite low in the GHS, just as they what they have performed in the field of the UHC. And we first combined and we first categorized the countries or the territories in this region into 4 combinations of the UHC and GHS capacities. As we can see in this figure on the right-hand side, there are only 9 countries, so most of them are high-income countries, as well as some of the upper middle-income countries. They perform well in both UHC and GHS compared to the world average, the world mean in the UHC and GHS score. So the world mean for the UHC score is 77 or 78, and the world mean for the GHS is 39, and only 9 countries in this region scored higher in these 2 areas in this region. And we can see that in this, and we can see in this slide as well, and most of the countries, so most of the Pacific Island countries and territories, as well as some of the Asian countries like Cambodia and also Laos and some others, and they scored lower than the world mean in these 2 dimensions. And only 2 countries, Philippines and Mongolia, they have a slightly higher score in the global health security, but lower UHC, but they are very close to the global mean. And we can see that no country fall in the UHC better than the GHS area. Yeah. Next slide. And if we run the correlation analysis between these 2 index, we can find very strong correlation relationship between the UHC SCI and the GHSCI, as well as between these 2 indexes and the sub-indexes as well. So the conclusion is that these 2 GHS and UHC are highly correlated. And in the second part, we look closer to the facilitators and barriers to the integration of UHC and GHS in this region. Next slide. And in this part, we conducted a case analysis for 4 countries. These are Mongolia, Cambodia, and Solomon Islands and Vanuatu. So 2 of them are Asian countries, 2 of them are Pacific Island countries, and all of them are lower middle income countries. Okay, next slide. As we can see in this table that all of them score a little bit lower or much lower than the global average of the UHC scores. And next slide. And except for Mongolia, it's just about a little bit above the global average. And all of these countries, they are also below the global average of the GHS scores. Okay, so we have looked at the contextual factors as well as the actors involved in the process of integration of GHS and UHC in these regions, in these 4 countries. And the first contextual factors, I think this is like protective factors or facilitators to the integration. This is the political commitment for include health in their constitutions or some regional vision. Okay, next slide. However, there are also a lot of key factors influencing the integration of UHC and GHS in this region. The first of all, it's the health system governance, and in the health system governance, the Ministry of Health played a very central role in coordinating UHC and GHS, and usually the UHC and GHS are part of the fundamental their functions of the MOH. So whether the MOH can coordinate UHC and GHS efforts depends on whether they have sufficient capacity to oversee the performance of the health sector. If they do not have the sufficient capacity, they may not function well in coordinating these 2 efforts. Okay, next slide. And also another issue in the health delivery system is that the primary healthcare system is very crucial for both UHC and GHS. If you do not have a strong primary healthcare system, you will not do well in both UHC and GHS. However, this is very challenging for many countries, especially in the Pacific Island countries. Okay, next slide. And another very important issue is about how the health system is financed. In many of these countries, they are both financed by external donors as well as internal payers. So basically the public expenditure, the government as well as some donors. And because many of these countries, they depend a lot on the external donors. So how the donors set priority for financing will influence the efforts in USC and GHS very much. Yeah, thank you. Next slide. And other contextual factors include the health workforce and also the availability of medical products and also the infrastructure of the health information system. If you do not have if there are no enough or sufficient health workforce, medical products, and a well-established health information system, there will also be a lot of challenges in integrating these two efforts in achieving UHC and GHS. Okay, next slide. And we have also analyzed some major actors outside these countries' governments. The first one is WHO. Actually, WHO has a quite balanced role in promoting UHC and GHS, and it's a high priority for WHO to advance in UHC, but it also has made a lot of efforts to promote the GHS in this region. Next slide. And we also found some other major donors, including Japan, Australia, and the Global Fund, and some other donors. These donors, they may have different priorities in financing the health system in these countries. Some of them have balanced strategies between GHS and UHC, and some of them emphasize the UHC more, and some of them emphasize GHS more. So if the donors have different opinions, or in many circumstances, they have a very important or high level of influence on how the government will pursue these two efforts. So the influence of donors cannot be neglected when we look at the integration of UHC and GHS in this region. Okay, next slide. And also next slide. Yeah. Yeah, next slide. And finally, we have some discussion points or policy implications. So first, the UHC and GHS actually share the same foundation. It's about the health system and capacities. And the primary healthcare system are very, very, very crucial for both of these efforts. If the health system is not strong enough, the UHC and GHS will be poor at the same time. If the health system is strong, and then you can achieve UHC and GHS at the same time. So they are highly correlated, and the major point is all about the health systems. And we also found that although the UHC and GHS are often both included in the health policy and planning, the strategic plan, the implementation remains very challenging. And the implementation is all about the workforce, the medical products, and the health information system, and also financing this kind of thing. So it can be very challenging, even though the policies have outlined the integration already. And in this region, the biggest gap is about the Pacific Island countries and territories, and they have huge gaps in both the UHC and GHS capacities. And future efforts or future attention should be directed to these countries. Yeah, thank you.
Thanks very much, Dr. Liang, for an excellent presentation. I'm sure the participants have noticed a great overlap between both the presentation of Professor Nasreen from Bangladesh and Dr. Liang from China, although they represent two different but probably sharing borders regions, but the problems remain the same. And the slides which I really liked from Dr. Liang's presentation include the slide number 10, where she actually divided the countries looking both at the UHC and the global health security together. And also the fact that she actually eloquently mentioned the contextual factors affecting both UHC and GHS, including the health systems, governance, finance, health workforce, medical products, and obviously a functional health information system. So this was really very good. the question for the participants, and especially the next two panelists, is the problem of UHC towards global health security only in low and middle income countries, or it is also in one way or another happening maybe in a different way and for different reasons in high income countries? And at this point, I'd like to invite Dr. Wael Al-Rais to tell us about the fact if the UHC is only a problem of high income countries. Dr. Wael Al-Rais is an assistant professor of health service research and co-director of Center for Global Health Security at the University of Nebraska Medical Center of USA. Dr. Wael, the floor is yours.
Thanks, Dr. Mandil, and thanks, Dr. Lee and Dr. Nasreen, for very interesting presentations. Dr. Prasad, do you want to, sorry, Dr. Mandil, but do you want to go first or should I go first?
I'm open either way. Dr. Mandil, you tell us.
It depends on what you have agreed upon in the last few weeks, because I know that there was a communication between Nebraska and Minnesota at the highest level in preparation for today's event. So, I mean, I'm very flexible myself. It all depends on what you agreed upon and how one set of comments would lead to the other.
I can go, a bit, particularly because of Professor D's presentation. It was a fantastic presentation, so I could go. So with your permission, Dr. Mandil, I can talk a little bit. I am looking outside my window here, and we had a late season dump of snow. About 20 centimeters of snow fell, and it's slowly melting away. But the reason I'm mentioning is not the snow, because it's not always that great, trust me. But I happen to go to probably the third biggest city in our state, a city called Duluth, Minnesota, which is up near the Canadian border. And our state here, the state of Minnesota, is not a huge, it's a pretty big state, but not hugely populated. It's about 5.8 million people, that's it. Not a huge area, right? The reason I'm mentioning this is I visited a hospital, a new hospital that was built there. And the amount of money it took to build a hospital was staggering. It was 1.2 billion US dollars for a 230 bed hospital. Okay, my work has been in the grassroots around the world. As a primary care physician, I used to work amongst rural communities, amongst tribal communities, in many countries, right? So when I see a number like that, it's a huge sticker shock for me, right? Can you imagine for 230 beds, 1.2 billion US dollars? So that brings up some very important questions. And both Dr. Nasreen and Dr. D touched on this. The cost of healthcare is something for us to keep in mind, right? Today, the US from the federal government spends about 1.5 trillion US dollars on healthcare. Now, this is just the federal government. It doesn't take into consideration the state governments, which also spend a lot of money, right? I want to give this in perspective. The entire GDP of Egypt, I just looked it up, is about $480 million a year. Okay, so the US spends more than double, I won't say about 4 times if you consider all the states together, of the GDP of Egypt. Now, the question for us is, are we getting the bang for the buck here? And my quick answer is no. I can finish my presentation by saying, absolutely not, we are not. So it brings up some very important considerations, because today when we look at healthcare, one of the important things to consider is what is our ceiling? What is our expectation of healthcare? I still continue to do clinical work. I'll tell you, I have a patient who's had 3 liver transplants. Because the first 2 failed, he's got a 3rd one. So from a public policy viewpoint, we ask the question, is this appropriate? Is this the kind of models we want to build? Because again, I'm not a heartless person. I'm not saying somebody shouldn't get a liver transplant. But from a public policy perspective, you have to ask the question, what is it that we are covering? And it is in this context that what Professor D mentioned is, I think, a very critical point. where is primary health care in the conversation of universal health care? Sorry, universal health coverage. And one important consideration for us to keep in mind is the essential difference between universal health coverage and universal health care. And I'm in no way saying that our friends who've done some fantastic job, Professor Nasreen, Professor D, their work is not important. I'm not saying that, right? I'm asking the question of the polarity that exists between the economics of healthcare and the care of healthcare. The majority of you, I'm assuming, are medical doctors. So in some ways, I would say that the presentations ahead of me were talking more about the anatomy of the structures, the coverages that are needed to build the structures that is very important for all communities around the world. I'm going to challenge us to also think about the physiology of the functioning of the systems that would take the coverage conversation to the next level and talk about it from a care viewpoint. Professor Mandil, your primary question for us is, have we achieved that here in high-income countries? And the quick answer is no. Our universal health coverage is pathetic. The US is really bad, particularly for a high-income country, for universal health coverage. You probably have heard our uninsured rate is pretty high. Obamacare, many of you have heard of Obamacare, did a really good attempt at covering more people. And yes, the coverage has definitely gotten better, but it's still not answered some of the primary questions about underinsurance, not just no insurance. In other words, on paper, you have insurance, but the insurance doesn't pay a whole lot. Then what is the point, right? And this is where I think the discordance appears between expectation of an individual, of a community, of people, of a whole country, and the affordability. This economic gap, expectations versus affordability, is a very important thing for us to keep in mind as we're talking about this. I'll give you two other quick examples before I want to elaborate on a couple of other points here. About 10 years ago, I was talking to the Minister of Health from Ethiopia, and he was lamenting the fact that there was a unit that was building up a kidney transplant program in Addis Ababa. And his concern, appropriately so, was as a not high-income country, is it appropriate for us to invest in a kidney transplant program, whereas we should have been doing more work in immunizations, nutrition, maternal and child health? The best return on investment economically, multiple studies around the world have shown, is in early childhood development. Shouldn't we be doing more of that than the kidney transplant program, right? This is something to keep in mind. Are we doing enough? The second is a reality that we're facing here in the US. Around COVID and after COVID, well, not after, during this COVID era, one of the biggest challenges we've seen is in the mental health coverage. A lot of our emergency rooms are filled with teenagers, adolescents with mental health challenges who are waiting for placement. It's a sad story that a high-income country is not able to take care of mental health aspects. And I would make a case that the models of mental health coverage we have in the US, which is a very highly individualistic one-on-one, you come to us and then we will decide what to do and then put you on a bunch of medicine, which is a different story in itself, is not working. And by the way, we have the highest percentage of psychiatrists per population in the world, roughly, for a big country. So if that is the case, we need to be looking at ourselves and saying, what is it that we are missing in this conversation in a high-income country? And this is where I feel when we talk about health, beyond the anatomy, the physiology of health, we need to look at health out in the communities, where healthcare workforce, as we define it now, may not be the answer. And the reason I'm bringing it up is in the US, there's a projected shortage of 125,000 physicians by 2030. Roughly 50 to 60,000 shortage of primary care physicians by 2030. Roughly 200,000 nurses shortage by about 2030 to 2035. I work in a large academic health center. I can tell you that all the academic health centers around the US combined together, we can't produce enough to keep up with that number. We have to start looking at our models. We have to start looking at our models in a way where we ask the question, while we are having this conversation about universal health coverage, it's important to understand primary healthcare and public health and look at healthcare delivery in the aspects outside the realm of a traditional clinic-based, highly concentrated setup like we have in the high-income country. So another quick message for you all, don't copy the US. Open up for more questions later.
Thank you, Professor Prasad. You are so humble, you didn't present yourself. So Professor Prasad is Professor of Family Medicine and Director of Center for Global Health at the University of Minnesota in the USA. And it was quite impressive how you actually differentiated between universal health care and universal health coverage, and the importance of supporting mental health through psychotherapy rather than pharmacotherapy. And also the fact that you emphasize the importance of affordability as well as accessibility. So this was the viewpoint from Minnesota. I wonder, the viewpoint from Nebraska, would it be different in the same country or not? Dr. Wael, the floor is yours.
Thanks a lot. I love this kind of discussions, and these are very thought-evoking points, actually. So building on what Dr. Prasad mentioned, the total healthcare expenditure in the US is $4.5 trillion, okay, which is it's just a scary number. And the T, which is a trillion, is 1,000 billion. So you can imagine the number. That's number one. The other thing which is very unique to the US has the highest expenditure in total and per capita. So the 4.5 trillion accounts for about 18% of the total US GDP. Okay, if you divide that by the total population, talk about $17,000 to $18,000 per year per person expenditure, which is of course far more any other developed country, and of course developing country. The point that I want to hear to again, so you have to understand that the issue of universal health coverage and the global health security are very complex and very unique to each country, and we can't cut and paste and say this have been applied there, let's do it here and we will be successful. No. And for that, actually, I'll present quickly two very interesting differences. I'll compare the US, which is a developed country, and Australia, which is also a developed country. Okay, giving the difference in population, of course, so Australia is like 25 million, the US is about 330 million. But the common thing here is their size. So Australia is a huge country or continent, and the US is a huge country, of course. But the two different models of healthcare systems are completely different. So the Australia implements a universal health coverage, although it took them 10 to 13 years to be successful in implementing that, but they started implementing that in 1980s. And every person in Australia is covered with universal health coverage. The opposite is in the US. So US adapts a combined private public healthcare financing system. And the other thing here, it's very independent. So any system in the US and any state in the US can decide what they want to do and what services they can offer and so on. So how is this reflected? So in Australia, as I just mentioned, 100% of the population is covered by universal health coverage or under the universal health coverage in Australia. In the US, about 9% or about 24 million people are uninsured, not underinsured, like Dr. Prasad mentioned. This is another group, but the uninsured is about 9%. So how can this be linked to global health security? I'll take an example, of course, with the COVID. So in Australia, there were only 10,000 deaths from the COVID. In the US, it was more than 1 million. Okay? So I think the message is clear. You can't actually achieve good global health security coverage or index unless you have good universal health coverage. And I think we're running out of time, so I'll stop here and we'll open it for a couple of questions.
Thank you so much, Dr. Wael Reyes, and thank you very much for the staggering statistics which you actually have witnessed, mentioned, and analyzed very eloquently. At this point, I'd like to turn back to Professor Tamer Amara to lead the Q&A in the minutes which remain. Thank you for the four speakers, Dr. Nasreen Sultana, Dr. Dee Liang, Dr. Shaili Prasad, and Dr. Wael Reyes. Professor Amara, the floor is yours.
Thank you all for the very interesting discussion, and looking back at the audience, if you have any questions, you can either type it or you can just say it in the coming few minutes.
So maybe I will start the discussion, Dr. Amara, if you allow me.
Please.
And Dr. Liang, what lessons have you learned from your study comparing important big countries in the Western Pacific with the island countries, which you mentioned? Big discrepancy, but common problems. What have you learned from that, and how can others learn from it?
Thank you, Dr. Mendio. So from my perspective, so the biggest take-home message is still about the health system and also the primary health care. And for the Pacific Island countries, they are it's particularly challenging for them to enhance their UHC and GHS capacity, is because they face a lot of challenges in building their own health system. They relied a lot on the donors to provide some the financing as well as the human resources and medical the medications, some other equipments. For example, during the COVID, they have a huge problem in accessing medications because they need everything exported from other countries, and during that time, it's impossible to have it. For example, if you have an HIV patient or malaria patient, and you are on an island and the medication is out of stock for 1 month, and it's impossible for you to keep your GHS or UHC work ongoing. And also they have a huge problem in testing the COVID in a timely manner, because they need to send all their sample to Australia or other countries. So it's almost impossible for them to timely monitor and also to contain the epidemic on the island. So it's very, very challenging for them due to the infrastructure, the human resources, and the resources overall. And for the Asian countries, they because they have a larger population size and they have better basis for providing care, and that's why they are better off. So the take-home message is that probably more attention and more resources should be directed to the least developed countries. Thank you.
Thank you, Dee, for your comment. And I think this concludes the session for today. We're just finished the 1 hour that is given to us, and we thank you all again, and we look forward to meeting you in upcoming webinars. Thank you.